Sulakshana, please confirm when Anna can do the welcome. Then she will do it.
Yes, so I think let's start, and I would request Anna to please welcome the participants and the panelists.
Okay, thanks, Sulakshana, and hi, welcome everyone. My name is Anna Vračar. I'm here on behalf of the G2H2 Steering Committee, and I am also an activist with the People's Health Movement. Of course, most of you who have registered will know that this is the last of our sessions from this week, which has brought you a series of policy debates ahead of the World Health Assembly, which is starting this weekend. So after discussing a number of topics over the course of the past days, including health emergencies and civil society interaction with the WHO, antimicrobial resistance and One Health, among other things, today we are here to talk about democratic and multilateral responses and how exactly multistakeholderism is affecting global health governance. So the policy debates, as you all know, or most of you know, are coordinated by G2H2, what is now already traditionally ahead of the meetings of WHO governing bodies. So we do this kind of debates every winter and every springtime in like Europe time, so in end of January and during May. And they are quite an important part of G2H2's work because, of course, we find that bringing people from civil society together, but also people who participate in the governing bodies meetings, like member state delegates, is an important part of how we can actually rebuild and reshape global health governance so it works for everyone. For those who would like to know more, I can just share a few brief notes on G2H2. So it's G2H2 is short for Geneva Global Health Hub, and it's a network of other associations and of organizations of people who want to advocate for a more democratic global health governance, and which believe that we can reshape this field, having in mind equity and dignity and accountability and justice before everything. So if you want to know more, please, you can visit our website, which is g2h2.org. There you can look up the past policy debates that we hosted, or the other publications and activities that G2H2 does. So not to take too much time, I will now hand over to Sulakshana, who is co-chair of the People's Health Movement Global. And she has been part of the coordinating team of this session, which is called Undermining Democratic and Multilateral Responses, Multistakeholderism in Global Health Governance. The session is organized by PHM, by the Transnational Institute, and by the People's Working Group on Multistakeholderism. So for those who will need interpretation from English to Spanish, if you have a look at the little globe in the toolbar below, you can just select the language that you want to use, and you will be able to hear it when you use your headset. So I think, okay, and I'm sorry, one last thing, if you have missed the past sessions of this week, you will be able to access them on G2H2 site, so make sure to visit it after to catch up on anything that you missed and wanted to see. And that's all from me. Welcome again, and Sulakshana, I'm handing over to you.
Yeah, thank you, Anna. And I too welcome all of you to this policy dialogue that has been organized by the People's Health Movement, the People's Working Group on Multistakeholderism, and G2H2 and Transnational Institute. I'm Sulakshana. I live and work in India. And I, along with Juliana, would be basically taking this discussion, moderating this discussion. I mean, just before we start, really feel free to introduce yourself in the chat and post your comments. We also have a question and answer box. You can also post some Q&As, questions there, which maybe our panelists would also simultaneously answer. And also, if any of you want to comment on anything and ask a question live. So after the presentations, we will have an open session where that would be possible. So at the WHO meets at the World Health Assembly on Sunday and throughout that week, this is really an opportunity for us to come together to interrogate and share our notes on the influence of corporate agenda on global health governance and global decision making and its implications for governments and people. And in that, we will today be particularly looking at, starting the conversation, looking at multi-stakeholder mechanisms. They also have a direct impact on people's health, their access to services, and the right to health. And there have been, several critiques and pushbacks by social movements and affected sectors on this dislocation of multilateral institutions. And today it's really an opportunity to share our thoughts and, join our struggles towards a more democratic and inclusive world. We are really honored to have with us 4 panelists who bring in a lot of experience and a lot of varied experience. I mean, even though I think the 4 panelists have so much in common, but I think it's really great that we also have, a variety of experiences on this panel. So I will just introduce the panelists first together. We have Madhuresh Kumar from the Transnational Institute. He's an Indian activist researcher who's currently based in Paris and is the project director of Global Gas Hub. And he was the national convener of National Alliance of People's Movements in India, responsible for policy, strategy, development, alliance building, etc. He has been involved in researching movement dynamics, alternatives to development and anti-globalization struggles. He is also an Atlantic Fellow for the Social and Economic Equity and the London School of Economics and Resistance Studies Fellow at the University of Massachusetts, Amherst. So I really thank Madhuresh for being here, and he's really been part of mapping the multi-stakeholderism initiatives that he will share in a bit. Then we are very, very pleased to have Dr. Fifa Rahman, who represents the global civil society on the WHO ACT Accelerator for access to COVID tools. She's a principal consultant in Matahari Global and a special advisor of health poverty action. She has had a global career in access to medicines and has been on missions to sites dispensing HIV services across the world. She has, she's widely published and supervises students working on intellectual property, including on privacy drones, on the work for higher doctrine and on intellectual property for COVID-19 tools. And we are very thrilled that she could make time to be with us in this conversation today. The third speaker that we have is Dr. Lauren Paremoer, who's a senior lecturer in the Political Studies Department at the University of Western Cape, South Africa. She teaches in areas of international relations, the politics of international economic relations, politics of African global South, third world politics, amongst others. And as a researcher, she's been focusing on health activism, global governance for health, and social movements and mobilization. Lauren has been a long-time PHM activist in the South Africa Country Circle And she's also the coordinator, one of the coordinators of thematic groups on trade and health systems within Global PHM. And currently, she also leads PHM's global program on global health governance and has participated in a number of the World Health Assemblies as a PHM WHO watcher. And we are very happy that she's here and, you know, to share the experiences. Then we have David McCoy, who's a public health doctor who was until recently professor of global health at the Queen Mary University. He's now with the International Institute for Global Health as part of the United Nations Universities. And his primary areas of interest and expertise are in the field of health systems, policy development, global health governance, political and economic determinants of health. And he has also been part of civil society organizations and networks such as the People's Health Movement, AIDS-PAN, and MedAct. I will now, and so welcome again to all of you, and welcome to the participants, to the attendees. And I would once again, reiterate that anybody who needs, this to be translated in Spanish should really, can use an interpretation, tool. And in fact, I don't know if one of the interpreters or Juliana or somebody could maybe speak that in Spanish about the interpretation, that'll be very useful. I don't know who can do that, but maybe before we start Madhuresh's presentation, it'll be useful to do that. So David Morris, please go ahead. And say this, you can share about the Spanish interpretation in Spanish.
I can do it.
Okay, Juliana, great. Yeah.
Para las personas que nos escuchan ahora, nos gustaría decir que tenemos interpretación en español. Solo es necesario activar el botoncito que está abajo, que dice Interpretation en Zoom. Y bueno, ya está activa. Y bienvenidos.
Thanks so much, Juliana. So I think we will start first with Madhuresh Kumar, and we've the People's Working Group on Multistakeholderism has recently launched the book, The Great Takeover: Mapping of Multistakeholderism in Global Governance. And I invite Madhuresh to share with this group the findings of this mapping and the details of this mapping, which has really been a very extensive and collective effort. So to you, Madhuresh.
Thank you very much. I'll just thank you. It's been really an honor to be here and make a small contribution. I'm not an expert of the health sector, and there are many more qualified people, so I'll just focus on the study we did and what our findings are from there.
So Madhuresh, can you just make it into a slideshow? And
yes, I'm doing that. Yes, sure. I'm just doing that. Early last year, we were Marianne, Mian, and I, both of us undertook this study on behalf of the People's Working Group on Multistakeholderism. And what we started with, that we looked at the 5 sectors: agriculture, climate change, health, data and internet, and education. We surveyed around 100 plus multi-stakeholder initiatives across these sectors. And what we came across was mind-boggling, in where we already know a lot of these things. But as we were dealing with the pandemic, and in the middle of the pandemic, what we come across is that the inequalities which we are facing, it became quite glaring. And this is something which our data also shows, that what are the reasons behind this glaring inequality. While those in the global north and also, or the rich and the poor, I would say, that the rich and in the north as well as in the south, they survived, but those who are at the bottom end, they are the ones who really suffered. So it's a glaring inequity in the health system, governance system, and it's as a result of that. And the multilateralism, what we all talk about, that is something which has been completely taken over. And where does power lie? That's what our study showed, that who is making these decisions. So just for the health governance, how in three ways the way it has been shown as that global health governance, global governance for health, and governance for global health. These are the three ways in which we can understand and look at the global health governance. Global health governance, where there's explicit mandates. So the World Health Organization has explicit mandate for that. Then there are global governance for health. So WTO, Human Rights Council, ILO, and others, they are the ones who would fall in this category. And then the governance for global health. So that would include the organizations or the national level of programs and policies which contribute to the global level governance. What we did for our purposes of our study is that this is the methodology we followed. We chose the time period given the time we had, 2000 to 2020. And then we found 17 MSIs who had significant impact into the health sector. And we divided them in different categories because this is where the MSIs were involved, the policy development, project implementation. And then we came financing facility very specifically. And then the paradigmatic or campaign mode, because some of them were launching polio campaign and AIDS campaign and others, which were very specifically targeted at a particular disease and launching of the universal health campaign for everybody. Then the typography, we found that there are some which are very much led by UN. Then there are academic institutions led, then there is corporate sector led, finance, and then there are issue specific and the academic institutions like the World Health Summit is led, the World Health Summit is led by academic institutions who are at the heart of it. The corporate sector led is the Gavi and the other Vaccine Alliance. They are the ones who are dominant players there. The financing mechanism is something like where we have the COVAX facility and the Global Fund and others. So these are the MSIs which we studied. And we see that from 2000 onwards to 2020, these are the 17 which we studied. The two in this set, Impact and the Global Health Workforce Alliance, both of them are no more active, but they fell within this time period. Global Health Workforce Alliance has now given way to Global Health Workforce Network, which is still in operation, and same the Impact Impact died down because of the controversy around counterfeit and IPR drugs and all. And these are the ones which we looked at. What do they tell us? And the 2 decades, this 2 decade we saw, this is like the golden age of the MSIs. This is when really the MSIs take root. And this is across the sector, I would say. The 5 sectors we studied, we found that post 2000, they became really a large number of MSIs came. And interestingly, that there is 2 times when there are like sudden growth or like high numbers of MSIs would be formed. And that's like the Millennium Development Goal and the Sustainable Development Goals. So those are the 2 periods when these 2 instruments were negotiated at the global level. That's when a number of MSIs also came in. So a lot of the MSIs we have studied across the sector, they all say that they are trying to implement the mandate which has been set by the UN institutions. So like the SDGs and the MDGs, these are the globally agreed goals which they are trying to implement. And MSIs play several roles. They are setting rules, standards, guidelines to funding, implementation mechanism, and they are also acting as conveners, facilitators, and networking hubs. So there is a big function which is being played by these MSIs in the policy realms. Then what are the things they are looking at, or what are the issues these MSIs are focused on? So COVID, definitely it's news in 2020, it just started and the COVID came into picture. Health security, human rights, medicines, data, health professionals, finance, right to health, vaccines. So in some ways it might look like that it's covering a broad range of issues. But I think this is slightly misleading, as we will see later, that they are in topic-wise coverage, it may look broad, but do they really have an impact, and how impactful they are in terms of what we really need? Sorry. One of the big things when we started segregating the typology, then we found that the project and the policy determination, that the 62% of the MSIs are primarily focused on the project and policy. 13% is around financing facility, and then the campaigns, so very targeted campaigns, those are around 25%. And lack of financing is something which is often given as a reason. If you look at even the World Health Organization, it is always struggling with the money problem, that they don't have money. But then how the money is given to the World Bank, that's World Health Organization, that's another issue, because assessed contributions by the member states, they are not, they are very few, it's decreasing over a period of time. But also what is happening is that they are facing different, many of them are very tied to project funding. So WHO doesn't have control over those funds, and they are already set, the agenda is set by those who are giving that money. And also what we see is that there is money for a specific diseases. So if in pre-2000, AIDS received a lot of money, then now post-2000 onwards, we see that the Global Fund and Gavi, their resources made available for specific diseases, but not for the overall health system. So as a result, we have greater focus on some issues, but not at the overall infrastructure of the health, which will ensure right to health to people. As a public health as a service, or public health as a right, that is something which is not fulfilled by these MSIs. And WHO, so I know WHO is always, we are trying to impact it, we are trying to make it better, and we do know that it has an important role within, and it does continue to have relevance, and it continues to also play a big role. So in the MSI version, what we looked at, that if you look, the WHO is, or in WHO plus UN systems, UNDP, UNICEF, and they are also involved in this count. So they are implementer, initiator, funder, host, strategic partner, member, leadership. So out of 17, in all 17, they are in a leadership position. So it means they sit in the board or the other things. So they do have an influence, but they are influenced, but does not necessarily mean they are there visible, but does not mean that they have the biggest impact or the influence on the many of these MSIs. In some cases, what we found is that this World Bank and the IMF, they are the ones who actually have more influence, and in terms of what WHO can do. So there is this great competition between them, even though the WHO is at the heart of the MSI system, because there are 111 partnerships and collaboration in various areas. WHO is and the health, if you look significantly, it's involved in the nutrition, air pollution, cities, hunger, poverty, education, governance. So it's embedded in the infrastructure, because health is very much related to the development agenda and the overall well-being. Now, private sector, this is where I think our concern comes in, that the role of private sector was huge, massive. If you look at this, so they are convener in one, advisory group in one, leadership. Out of 17, in 12, they are playing a leadership role, of which 12 they are funders. So they are also funding a lot of that. And why the funding is important, we'll see later. Implementer, they are strategic partners. They are initiators, conveners, they are host. Host means they host those organizations. They are playing a big role in providing infrastructure support as the host to some of these MSIs. And the door to this was opened through the FENSA, the Framework for Engagement with the Non-State Actors, which was passed in the World Health Assembly in 2016. And I think that's still a way of contention between civil society and others, that how they have found the private sector has found a backdoor entry into this. It's not that the influence of the private sector is not challenged, or it's WHO or the Director General, they don't know. They do know about this, and this is always a constant talk of. There is a constant talk about it, but what are we doing about it? That's not very clear. In fact, we seem to be giving way to it. And if you look at the lead actors' involvement within the MSIs, so who are the lead actors in most of these? So we did this. So if you look at the UN body, still is 26%, but then this one, which you can't read, the development finance institutions and the IFIs, they have roughly another similar 24% of that. And philanthropies, they are 15%. Philanthropies are a big influence within the MSIs, which is shaping agenda, and the government's 4%. So we have made a distinction between government and the northern donor government. Northern is the global north organizations, OECD countries mostly, and the government's 4%. So that's the global south governments who have limited role and influence within the MSIs. And that's where, so a big chunk of global population, their sovereign governments don't have much influence within the MSIs. In fact, compared to that, the international NGOs have more influence, seems to like 8% of the academic research institutions, 7%, they have more influence there. Business has 9%. So this was something very eye-opening for us. Within the leading, so we'll try to look at who are the top 10 influential actors. And then we found the WHO has the 16 occurrences out of 17. The Bill and Melinda Gates Foundation, 13 cases, they are the ones who are the most influential actor in many of these MSIs. World Bank is 12, and then the UNICEF 7, the Gavi at 6. And we all know that in the Gavi Global Fund and all the Bill and Melinda Gates Foundation have their role as well there too. So this is something which is really eye-opening for us. Now, there are 6 financing facilities. So financing facility MSIs, Gavi, Global Fund, CEPI, Act A, and then the COVAX. This is what the percentage-wise involvement of actors in the funding of MSIs. The development finance institutions continue to have 22%, UN bodies 17%, Northern donor government and the DFIs. So DFIs also, if we all know that how US, UK, and Japan and other countries dominate and control the development finance institution as well as IFIs. So they have a big, in fact, they do have a greater influence and the money power in most of these cases where when it comes to financing of that. So WHO and UN bodies are important players, but they don't control the finances, as I mentioned before as well. And the most shocking was that since the time Bill and Melinda Gates Foundation was founded in 2000, and since then, the global health governance has completely changed because they are providing resources in several forms to WHO, UN organizations, development financing institutions, NGOs, academic and research institutions, developing country governments, INGOs, CSOs, and the list goes on. So they, in a way, are finding these people and supporting everybody. In fact, there is a big revolving door, which we didn't have time to get into, that how those who serve in the foundation, they come to the UN, then they come to WHO, then they go to some government position, then they go to IFI and the IMF. So there is a big revolving door which is there, which exists and has an immense influence on the agenda, and the BMGF is behind that. In fact, Anne Emanuel Burns, she studied the role of, she was comparing the Rockefeller Foundation and the BMGF role. And what she said is that the Rockefeller, what they did in 19th century, when they had immense influence over the global health governance agenda, the BMGF is now the leading one in the 20th century. And they are the 21st century, and they are the ones have such an influence that, in fact, as citizens and as civil society organizations, we are concerned about it, but the scientific community and the academic community, they should be also concerned by it, because the influence the BMGF has on this agenda. So we should try and definitely look at that. What is the way ahead for us? What can we do? I know that the WMSIs are significantly undermining the global health agenda, and it's completely, they are not accountable, and we can hold our governments accountable, we can hold multilateral institutions accountable, but they are not accountable. And I think it's the only ways that how do we have greater collaboration between nation states and the multilateral institutions. We need to strengthen them. I know there are problems with the WHO and other UN bodies, but we need reforms, but not reforms led by the corporate sector and the neoliberal reforms agenda. Thank you very much.
Thank you very much, Madhuresh, for that. And I hope that, all of us, during our discussions today, we will really also go more into the way we, work ahead. And thanks for really, I think, highlighting, one important thing, the aspect of financing and the issue of conflict of interest. And as we know, in the upcoming World Health Assembly, there's a proposal that, the assessed contributions would be increased to achieve 50% of the base budget by 28-29, which is very non-ambitious. So, I mean, I think, like you said, you know, for change to actually happen, one has to be more ambitious, and one has to be, you know, sort of really, you know, go forward in leaps and bounds rather than just discussing some of these issues. So I now welcome Dr. Fifa Rahman, who is going to speak about the future of the ACT Accelerator and 4 non-negotiable demands by civil society organizations. As you may all know, the ACT Accelerator is a global collaboration to accelerate development, production, and equitable access to COVID tests, treatment, and vaccines. And it brings together governments, health organizations, businesses, scientists, civil society, philanthropists for this purpose. So we're very happy that Dr. Fifa is with us here. So yeah, back to you, Fifa.
Thanks very much for the introduction. And I'm sort of going to apologize first because I'm operating on heavy jet lag. So if words don't make sense for a little bit, please feel free to point it out. And I'm going to start sort of with the structure of the Act Accelerator. Now, this is the boring part, but it's important because when there's a lot of critique of the Act Accelerator, it's often just because of the COVAX, and there's not much awareness on what the therapeutics, diagnostics, and health systems and response connector has done. So it's important for me to explain that there are 4 pillars, and they have different co-leads. So you've got Gavi and CEPI on the vaccines pillar, Find and Global Fund on diagnostics, United and Wellcome Trust on therapeutics, and health systems and response, WHO, and others. There's so many groups in there. And I just wanted to give you an example of a slide from the Act Diagnostics pillar from June 2021 on some of the things that they wanted to do, which is procuring and deploying 900 million tests, developing multi-pathogen platforms and sequencing, which we're actually still talking about, and others, right? And at this time, self-testing wasn't quite a feature, but it became quite a feature later on. So just to quickly jump through, you know, it's quite clear that the global health architecture on pandemic response hasn't been perfect. And I think everybody acknowledges that, and that's why there are several efforts underway to sort of plan for the future pandemic response and to fix the global health architecture on it, or at least make some improvements. And we've been struggling around the words reform, reinvent, you know, what exactly is it? But, you know, I want to talk about this article from the Bureau of Investigative Journalism about how unglobal our global health is, right? And of course, the Act Accelerator is global North white led, and that is an important fact that we need to discuss, and what the effects on a predominantly white global North architecture has on access to commodities. Now, this is an article about COVAX, of course, and you've got situations where people were ignored, governments were ignored, phones were not picked up, relationships got a little ugly at times. And there's also a situation where back in the day when DRC returned its vaccines to the COVAX, the very next day I called a colleague in DRC and said, you know, what's the situation, what it is needed. And he told me quite clearly there's been a failure to leverage upon the community health workers that were, you know, that worked in the Ebola response. There's been a failure to engage provincial health leadership. So, you know, the consultations weren't done. And if you had somebody from the DRC, an expert from the DRC, on the platform ready, you know, at your hand, and that's the strength of CSOs, right? We have those contacts across the world, and we know how to leverage and center that indigenous expertise in these things, in these efforts, and clearly that didn't happen in the COVAX. So, you know, the situation, the global health architecture not really being global is a real problem. Now, race discourse is really important because this is an article that I wrote together with my colleagues, Caroline Gomes and Brooke Baker. And all three of us are on the diagnostics pillar of the Act Accelerator. And of course, I play the role as the lead CSO rep that sort of presents at the Facilitation Council, which is where the member states sit. And we kept hearing for 8 months or more, we were pushing and pushing and pushing on self-tests. By this time, and I normally I live in the global north, I live in the UK, I'm calling from Malaysia this time. You know, we had self-tests all over the global north, and we'd been pushing for 8 months, and we kept hearing this, people need to have access to self-tests only if they can link to public health action, only if people know how to link to treatment. And I remember that call when that happened, and all the CSOs, and we're predominantly from the HIV/TB world. So when we hear this language, we're reminded of what then chief of USAID said, that, you know, Africans don't know what watches and clocks are. So it was something that we had to remind us. And this article actually led to a meeting with Tedros about pushing self-tests, and it was a big thing because, you know, there were colleagues in the WHO that said, we dropped the ball on this, we need to push it. And that's when the guidelines of the self-test came out, because of the significant pressure that was put on, right? So that's more illustration on sort of on the unglobal nature of global health, right? And of course, we all know about the vaccine hesitancy situation and the fact that it hasn't been sufficiently nuanced. So I want to illustrate with this slide from the wonderful Dr. Mamunur Rahman Malik, who is the WHO country rep for Somalia, and we have his authorization to share his slides today. And even with the situation that Somalia faced, so they faced a situation where their vaccines were stuck in the Nairobi facility, and they didn't have, so there was no funding for the charter flight to bring the vaccines from Nairobi to Somalia. So there were massive delays, and they had to get money out of their the current budgets. They had to use syringes from routine immunization, and you know that wasn't being replenished quickly enough. But even with all these hiccups, right, they administered 90% of the doses provided to them. So, you know, obviously there is some issue with, you know, legitimate concerns people might have, hesitancy, if you want to call it that, in you know, higher in certain countries than others, but certainly it's been insufficiently nuanced. So what next for the Act Accelerator and future pandemic response? There are a number of conversations going on. So on 4th May, I want to talk about the second one first, and it's sorry for not ordering it in sort of chronological order, but the WHO consultation paper on 4th May 2022 was circulated to a number of stakeholders, including CSOs, and we have responded to this. And there's a bunch of things in there, including the need to address community concerns beyond the health sector, effects on lives and livelihoods as a key part of building trust, which we obviously agree on. And that the existing global health emergency workforce is too dependent on the goodwill of ad hoc voluntary contributions, which of course was a big killer, because when the global north decided that the pandemic was over, it resulted in a real loss of momentum, right? Concurrently, there is a G20-led, and of course led by the government of Indonesia, discussions on pursuing a permanent structure for developing and ensuring critical access to medical countermeasures. They will be having a meeting in Lombok in Indonesia in second week of June 2022, and there'll be a number of folks from the Act Accelerator and the COVID response presenting in that. And I've just received an invitation to speak on, you know, what the value of LMICs are in these responses, because clearly LMICs have not been sufficiently consulted. There hasn't been LMIC experts. I remember from the early days of the Act Accelerator that they were just not sufficiently listened to. So you saw LMIC experts, epidemiologists, diagnostics experts, World Bank, black and brown people from World Bank, just dropping off calls. They were just, you know, slowly just not attending, right? How do we fix that? how do we fix that sort of structure that's sort of ingrained in the current systems, right? So so basically from this, we as CSOs have 4 non-negotiable demands, and it was initially 3 in my last facilitation council speech, but in further discussion with the CSO constituency of the Act Accelerator, we added a 4th. So the first is equal intellectual partnership of LMICs. Now, a lot of the folks in the global North dominated global health architecture don't know what this means, because I've said it so many times and nobody changed anything. So we're making a number of concrete proposals in relation to this. And one of them, and this could change, of course, because we're still discussing it internally, but it could be a council of LMIC experts. So it could be LMIC experts, epidemiologists, clinicians, nurses, community mobilization experts, CSOs, health comms, health econs people, all from LMICs in a council that provide opinions on decisions, right? And that's one of the options. But a few people said, no, well, how do we compel global health agencies to run these decisions by this LMIC council is something that we think about. Anyways, the second one, to not use up all the time, is the co-creation of decisions with CSOs. Now, this happened in varying degrees in the different pillars. Now, forget about that occurring properly in the COVAX. I think the response would have been better if Gavi and CEPI had co-created decisions with CSOs. But with FIND, the diagnostics pillars, this was more, this happened more often. And I had, more or less regular calls with Bill Rodriguez, the CEO of FIND, and the other senior management members of FIND were like going, hey, what do you think about this? It was more consultative for sure. And of course, Unitate's experience with CSOs as well. But it's definitely something that needs to be pushed more with the agencies who are less comfortable with CSOs. A new TRIPS order is the third one. And of course, this applies to more technologies than others. With diagnostics, it's not so much of an issue, IP. But we definitely want to see a new TRIPS order, because the way it's happening and waiting forever for a TRIPS waiver that doesn't seem like it's going to materialize is not the way we should go in the next pandemic. And the next is feeding off the previous speaker's presentation as well, is that health systems and response should be central and not ancillary to emergency response. And we saw that, quite starkly in the Act Accelerator, where, they promised this pillar, promised 14 work packages. And as of February 2022, only 1 had sat. So that's pretty horrific. And, it resulted in all this controversy about FIFA, why did you call this out in open floor? Don't do that kind of thing. And I'm like, if you promise 14 work packages, you should deliver on 14 work packages, especially when it's something as important as health systems and response. So, I'm happy to end there, and I know it was a lot, but happy to answer any questions on that. Thanks.
Thanks so much, FIFA. I think I can really endorse also that, I think the way forward and the issues that you have highlighted is also something that I think the broader civil society is also asking, of the ACT Accelerator about, equal participation of LMICs, about, how it is engaging with the TRIPS waiver, and, and also what are the sort of the larger comprehensive interventions on health systems that are required, and what actions must civil society take, the larger civil society, to ensure accountability. And I do hope, we'll continue this conversation. And thank you very much for, I think, highlighting the issue of race, of inequalities. I think that's a conversation we don't have very, we usually don't have it very candidly in global health even. One has it in different languages, and I think it's very important that the nomenclature is just put out there. So thanks a lot. So I will now request Lauren to present, and Lauren would be talking about the about building campaigns from the country to the global level against corporate capture of multilateral institutions, and also would be speaking about the about people's health movements, equitable access to essential health technologies project or initiative. That is one of the main engagements of PHM under the Trade and Health Thematic Circle and the Equitable Health Systems Thematic Circle, which sort of focuses on monitoring and reporting what is happening at the community level and to engaging at the provincial and national levels, and also at the global level. So I welcome Lauren to share the experiences.
Thanks, Sulakshana, and good day to everyone. So I apologize in advance, and I'll be leaving early, and it's really a sad thing for me because I would like to stay to follow the discussion. So Sulakshana introduced me by saying that I'll speak from the experience of a research project that we did in PHM South Africa. Two similar projects ran in India and South Korea. And it was looking at examining the barriers to equitable access to COVID-19 diagnostics, vaccines, and therapeutics. That project was done in South Africa in collaboration with Professor Leslie London and Aline Tukukilare, both of whom are PHM members, and then two students of Leslie London's, Alaya Banwari and Larato Shlongwane. And Larato was the person responsible for managing the community monitoring aspect of the project. So I want to say that even though I'm supposed to speak about building campaigns, I fear that my talk ended up being much more about obstacles to building campaigns. And I think that's a reflection of the vast resource inequalities. So both money, like material inequalities, but also less tangible inequalities. For example, access to the English language, inequalities of status. People mentioned race, but there's also sex, for example, citizenship status, all of these things that function as barriers to public space, and particularly so in terms of public spaces that are monitored or regulated by the government. So maybe just to start with the material resources. In South Africa, a lot of the pandemic response was financed or subsidized through a fund that the president set up, the Global Fund, the Solidarity Fund. And just as an illustration of the level of inequality in South Africa, two families, private families, when the fund was started, pledged 1 billion rands each towards the fund, which would be used to help with COVID responses. And that's it's a matter of a phone call from the president to these families. At the same time, during COVID, we saw almost half of the population, 46%, going hungry. We saw 3 million job losses, 2 million of which were job losses suffered by women, Black working class women mainly. So this is the context in which in South Africa, people were trying to organize in order to access vaccines and to not only access vaccines, access all of the other services that they needed to survive, right? Food, energy, etc., etc. And so I think, one thing that we need to keep in mind is that this inequality of access to resources at the domestic level really had, I want to say chilling, but maybe not chilling. It had, it fundamentally undermined the time and energy people had for political organizing, but also the infrastructure they needed to organize, particularly during lockdown conditions associated with COVID. So something as simple as having electricity to charge a phone so that you could join a Zoom meeting. Zoom meetings became very important as a kind of organizing space. Something as simple as having cell phone data. All of these things constrain people's ability to organize, to get together, and to share information, for example, about where to access vaccines, how to do so, whether it was safe or not, etc., etc. And so I think this is the first thing that's really important to note. I think as a result, one of the kind of complicating factors, at least in South Africa, is that the the organizations that did tend to have access to political space. And this, I think, to some extent includes civil society, a broad civil society campaign that was advocating for access to vaccines, that there was this relationship that developed where the civil society organizations that were capable of supplementing government efforts to roll out vaccines or to act as implementing partners, perhaps in the sense of promoting access to reliable information about vaccination, that these were the organizations that also had greater access to political space and resources, right? So I think this is also something for us to keep in mind, because the discussion of the grassroots and the national level matters, to the extent that that's the major entry point into whatever regional or global political discussions are possible. And so the one basic remark is that that's a very contested but also unequal space. The other thing I think to keep in mind, and this also is from the experience in South Africa, is that quite often the national level space, yes, can be a space of cooperation between government and grassroots organizations, civil society, but it can also be a very contested one. So I think one of the things that's fundamental to building campaigns, particularly campaigns against corporate capture, is access to reliable information. Unfortunately, I think in many places, including South Africa, the procurement, distribution, decision-making around selection of vaccines, all of these kinds of issues have been subject either to formal non-disclosure agreements, for example, when governments contract with vaccine companies, but also, quite often ministerial advisory processes around which vaccines to select, prioritization of groups to receive vaccines and so on. These things are not necessarily transparent. And where civil society has asked for information, this information hasn't always been forthcoming. And so it also means that, again, if you're looking at the national level, there is sometimes a tendency for conflict or friction to build up between grassroots campaigns, civil society organizations that are advocating for vaccine equity, and the national government that's often betwixt and between, trying to get access to the resources it needs, for example, vaccines, but also as a result of a skewed trading system, being pressured into basically an arrangement where it's unable to provide information to its citizens without being sued, and citizens therefore being fundamentally unable to hold government to account for how public money and resources is administered. And so I think if the state or the national government level is our entry point as civil society organizations to have a voice at multilateral institutions, then that's another constraining factor, because our states, as a result of some of these domestic conflicts, are not always willing to listen to us and to carry our message with them when they attend these multilateral institutions. I think also for states, and I think this is reflected in the report that Tia and I did, for states also there's a closing down of space in these multilateral forums. So even when they do take civil society voices with them, one space is closed down in the sense that the locus of decision-making moves into these public health partnerships. But also, I think, as Madhuresh pointed out, sometimes in multilateral institutions, less space at the decision-making table is afforded to states, for example, from the global south, as compared to NGOs from the global north, right? So it's also that sometimes progressive allies have more space in these forums because of technical capacity, resources, political relationships, and so forth, than global south states. And so I think that's another complication or tension to keep in mind. And then I think the final thing that I want to flag, and I think it connects somewhat to what FIFA was speaking about, is the issue of expertise. So I think in the community monitoring project, especially, we had 6 community monitors observing, people's access to basic things like water, soap, but also their access to vaccination sites, isolation facilities, and so forth. That was run in 5 provinces, 5 neighborhoods across South Africa. And what's really clear is that people have a real level of expertise about their community, about barriers to healthcare access in their community. They have a lot of information, even without formal monitoring, about the kinds of impediments to implementing vertical interventions. So they understand how the clinic system works and what needs to change about the holistic system in order for a vertical intervention like a vaccine to seem like a feasible prospect, right? Because if I go for a vaccine, but I've been off my HIV/AIDS meds for a couple of months because of the lockdown, what's going to happen? It's not a once-off consultation that you need. Monitors are able to tell you these things. And I think because of how global governance institutions are configured, someone like a community monitor would never have the opportunity to share that expertise in these spaces. I think the people that do share expertise are the people that have expertise, perhaps one can say expertise of how to negotiate and operate in those global governance institutions. So for example, someone who's based at Gavi has expertise on how to create a market for vaccines. They can take that to COVAX and create a pre-purchase market for vaccines for COVID. And then they can advocate for creating a similar kind of COVAX-like mechanism for future pandemics. That's the expertise. They're not necessarily able to translate into that expertise into a meaningful health system intervention at national or grassroots level. That means that once vaccines come into the country, they actually become more than medicine in bottles. They actually become an intervention that makes an impact on people's lives. And I think that for me is a big part of the disconnect, that grassroots campaigns are kind of, not grassroots campaigns, that one of the fundamental blockages, I think, for building campaigns against corporate capture is simply that the forms of expertise that are needed to really transform health systems in order to realize health for all, that those forms of expertise are locked out. Instead, what we have are forms of expertise that I would argue are targeted towards figuring out how people with existing interests in the global health governance system, and those might be public or private institutions, can continue to secure a seat at the table. And I think that has profound and very damaging consequences for achieving health for all. So I'll stop there and say thank you very much and a preemptive goodbye.
Yeah, thanks so much, Lauren. I mean, really thank you for, reflecting and reminding us, one, that, civil society is not a homogeneous place, and, it is an unequal space. And we really need to reflect, when we talk about civil society participation, what it really means at different levels. And also the point to make about, transparency in information and, access to information, whether it's contracts or, whether it's, very basic thing about, whether, who is, which health workers are posted at a particular health center. And I think the other point about decreasing civil society spaces and, and really the attacks on civil society, I think that's something, we all, I don't know whether we've spoken about it at the G2H2 policy dialogues, but, I think even within the WHO and within, the kind of dialogues that we're having, I think it's really important to look at the way governments are coming down on civil society, and because that's really going to affect the way civil society is able to, participate in these processes. And I think lastly, the important point about how evidence or expertise is, articulated is or created or used or developed or recognized. I think that's again a very critical point. So thank you for that. Now I would request David McCoy to speak on a very, very powerful paper that's just been published, and with him and others as authors on corporate lobbying on the US positions towards the WHO, which it seems is the first comprehensive study of expenditures on lobbying of the US federal government linked to discussions seeking to shape US policy towards how it intervenes in the World Health Organization. And we are really glad that, we were able to add this at the last moment, because I think it really very well sort of, supplements the discussions that we are having today. So David, please go ahead.
Thanks, Sulakshana. And also thank you to the Geneva Global Health Hub for making this opportunity to present this paper, which was only published about 2 days ago. So let me just begin by saying that this was research led by Professor Katie Russ, based in California. And really the only reason I'm presenting it is because it's 2 o'clock in the morning out there on the West Coast. Now, what I want to do is really present the data that is available in this paper, because I provide a broad overview of it, because really there's a lot of detail in this paper about the way in which corporate actors seek to influence, shape, and to a large extent undermine WHO by influencing the US government and the US government's position with regards to WHO. So this is a paper, research paper, that aims to describe the stance of commercial actors towards WHO, but how they do this indirectly via the US government. So very briefly, let me just describe the data that we looked at. And there were really 3 broad sources of data. The first is the public disclosures that are required by law of all actors that seek to lobby the US government. So there is an act that was passed by the US Senate requiring actors that lobby the US government to declare how much money is spent on their lobbying activities and to provide a description of the issues that they're lobbying. And this data has been aggregated and placed into a database by a group based in a university in Michigan. And they have collated that data into a database that's called LobbyView. And we looked at all of this disclosure data as it relates to WHO. So we did a search of all the disclosures, looking for words related to WHO or to the World Health Assembly in order to be able to extract data related to lobbying as it pertains to WHO. The second source of data relates to information that we were able to obtain from the websites of those actors that were reported in these disclosures, position statements filed for public consultations held by WHO, the legislative archives of the US Congress, information obtained from news media, and also from academic articles. And this was really to try and get some additional data about the kinds of positions that these corporate actors have adopted with regards to WHO policy or WHO positions in a variety of global health issues. So this was really an attempt to triangulate data from multiple sources. Now, after we did some initial research, we discovered that many of the corporate actors that were lobbying on WHO issues were linked to an industry group called Engaging America's Global Leadership. This is a group called EAGLE, that's the acronym. And this is EAGLE is an organization that was set up in 2016. And we just happened to notice a strong association between the actors lobbying on WHO and their links with this new group called EAGLE. And we subsequently submitted freedom of information requests to the Office of the United States Trade Representative, requesting all correspondence between the USTR and EAGLE, as well as a range of other industry bodies. And basically, we were requesting any correspondence that included keywords related to WHO. So this is the data sources that we looked at and that fed into this paper that has just been published. So let me briefly describe some of the key findings. So the first thing is that we looked at the expenditure that has occurred on a year-by-year basis, looking at this as being expenditure on lobbying related to WHO. And you can see from this graph here that expenditure post-2016, which is the year in which EAGLE was established, rose considerably, and there was also a considerable spike in lobbying in 2020. And so it does look as though after 2016, lobbying on WHO-related matters increased. There was a spike in 2020, and this, of course, coincided with the announcement by the Trump administration that the US would withdraw from WHO and stop providing funding to WHO. And you can also see that between 2016 and 2020, there was a large proportion of the people lobbying about WHO were associated with this new body called EAGLE. Now, in the paper, we described that the corporate actors lobbying about WHO came from a wide range of different types of industry bodies. Some of the lobbyists were individual firms, but many of the lobbyists were, the clients of the lobbyists were in fact umbrella organizations or coalitions of different industry groups, not representing one company and not necessarily representing one sector of industry. But EAGLE is really, in particular, describes or it exemplifies a body that attempts to coalesce the interests of industry groups that come from many multiple sectors. Since 2016, we noticed that parties associated with the production or marketing of breast milk substitutes, alcohol, biotechnology, and pharmaceuticals were consistently amongst the top 10 sources of lobbying expenditures related to WHO. As I mentioned earlier, there was a strong link between parties engaged in lobbying after 2016 with EAGLE. So what is EAGLE? So EAGLE describes itself as a coalition of industry associations that addresses, and I quote, problematic and divisive initiatives created or produced by multilateral institutions like the WHO, OECD, ILO, and UNEP. So this is information that we've taken from their website. And they describe these problematic and divisive initiatives as being initiatives that reach well beyond the core missions or mandates of these multilateral institutions. And NAM, which is the National Association of Manufacturers, another US-based umbrella organization for US companies, also in 2017 described and named the UN, WHO, and the OECD as engaging in activities that were detrimental to American manufacturing and jobs, and stated that the EAGLE coalition, which NAM helped to set up, would exist to seek robust US leadership in these multilateral institutions, including through work with the Trump administration and Congress, to hold these institutions accountable, to improve US oversight and coordination, and expand the efforts of the US and other governments to speak with one voice about the problems and the divisive initiatives of multilateral institutions. So we also looked at the disclosed positions that these lobbyists were taking in relation to WHO. And we present in the paper 3 types of positions with regards to WHO. One set of positions was related to lobbying designed to influence or shape WHO guidelines and policies. And examples include the National Milk Producers Federation lobbying the US government, advocating for modifications to a proposal to restrict marketing of follow-up commercial milk formula. And there are many other examples of corporate bodies seeking to influence WHO guidelines and policies through the US government. The second set of lobbying issues were related to WHO's own procedures and operations, so their own internal policies about how WHO itself operates. And for example, Mars, the confectionery chocolate producer, lobbied the US government, advocating for greater private sector collaboration or greater collaboration between the private sector and WHO. And several private sector actors lobbied about non-specific issues related to WHO priorities and to WHO reform in broad terms. And then the third set of issues that the corporate actors were lobbying on related to US government engagement with WHO itself. And here, amongst the issues that some of these bodies were lobbying about was about the composition of the US delegation to WHO, and then also about US funding of WHO specifically. Now, when we looked at some of the other information to try and deduce the kinds of arguments and narratives.
David, sorry, just just interrupting to say if you could just wind up in a couple of minutes.
Sorry. You know, to try and find the kinds of narratives and arguments used by these corporate actors, we described kind of three broad arguments. One was related to the negative impact of WHO policies and guidelines on US citizens and the US economy. The second were arguments about the overreach of global institutions. And you see, here you can see language such as Congress needing to act to reform rogue international institutions, or trying to hold multilateral institutions who are to account for acting with insufficient accountability and transparency. And then the third set of arguments was about the non-scientific nature of multilateral policy and guidelines, in particular making reference to WHO policies as being non-scientific and not based on adequate evidence. So I'll just stop there, and I hope that provides a kind of useful overview of the material that's in this paper. But I really would encourage you all to read the paper and to also kind of try and help us to determine how this data can be used, how it can be disseminated, and to which audiences we should try and attempt to provide this information to. Thanks.
Yeah, thanks, David. I think it's a really important paper for all of us, and I mean, I think it I think to this discussion it also contributes the issue of how countries and governments continuously get influenced by private sector lobby and industry, and which really influences their contribution, participation in global health and multilateral institutions. So so when looking at multi-stakeholderism and the and democratizing global health governance, it's really important to look at it at all levels, and and act on it, or take the work forward on all these levels. So thanks a lot. So I've been requesting the participants to indicate if anybody wants to make an oral intervention. It is still, the floor is still open for that. We have around 15 minutes, I think, left of discussion time. But I think I will just start off, with a question to all the panelists, or anybody, who wants to respond. I mean, maybe starting from FIFA. So there are a couple of comments in the chat box, about, do we, I mean, basically the question is, do we, I mean, how do we do away with the multi-stakeholder initiatives? Or, how, I mean, when you actually want to look at alternatives, or you actually want to look at democratizing global health governance. So, I mean, ideally, what systems should be there, and, and can multi-stakeholder initiatives really be democratized, or, so, that's a question. So, yeah, just your thoughts of the panelists on that. And after that, I think Patty would want to say something, but maybe, yeah. So once we have a round of the panelists. after. Yeah, Fifa, please go ahead.
Thanks, Sulakshana. So it's something that we've been discussing a lot, how, and reinvention is our favorite word right now, just because the structure is better than nothing, but at the same time, you cannot have global North agencies leading global health. It's not really global if that, is being done. And, I remember these facilitation council meetings and the principals group meetings. So the principals group meetings is where the heads of agencies and senior staff of these agencies meet bi-weekly on Thursdays, and I'm the CSO rep in that, in those discussions. And Africa CDC rarely attended, right? And and of course, Africa CDC was creating this whole movement with, their own thing where they were going new public health order, all of this, and they're doing great things on that regard. But the fact that they didn't have, they didn't have as prominent a role in a global response is a little bit nuts. And you saw also Soji Adeyi, for example, who is maybe the smartest person I've ever met. Former head of nutrition at World Bank, eminent Nigerian. The fact that I remember he was also attending a lot of the Act Accelerator calls in the start, and then we didn't see him that often anymore. And there's so many other examples of people just dropping off. And why is that? There is a reason for that. And of course, some of us remember kind of disrespectful conversations where they go like, no, we don't think that your expertise is correct. And you're like, yeah, you sitting in Geneva in your organization and not having necessarily the indigenous expertise, no better than this African expert. It's just a little bit, there's quite a lot of that. And we cannot have global health architecture that works for pandemic response, which is predominantly led by global North agencies. That's just not the way that it's going to work. It's going to fail every time, or it's just not going to fully reach the potential that it should. So how do we reinvent? We start with an LMIC council, but then how do we expand? And how it's still subject to so much thought, and we need to brainstorm more on it.
Thanks so much, FIFA. David, would you like to respond to that? And especially now that you're in Malaysia, I think it'll be good to hear from you, how you think these things can be done.
Yeah, I mean, I think this data that presented is useful in the sense that it shows that on the one hand, you've got these corporate actors actively undermining WHO, questioning its scientific credibility, calling on the US government to limit funding. And then on the other hand, they're also trying to say, we want to work in partnership with you guys. And I think this kind of double standard is important to kind of reveal and show that there is a danger in these multi-stakeholder forums in legitimizing their role in governance, but also in effectively legitimizing the way in which they're also seeking to actively undermine these very systems of governance. But what's also important, I think, is that we have some hard data describing the narratives that they use, the arguments they use for undermining multilateral governance and WHO in particular. We're lucky in the sense that some of this data is legally required to be put into the public domain. The European Union, on the other hand, for example, does not have the same requirement, and we still are almost certain to have the same patterns of corporate activity occurring at that level and with other high income country governments. So there's also a need to do further investigative work to be able to uncover this kind of behavior. Thanks.
Yeah, thanks, David. I mean, I think I think what we're also, what we're basically seeing is that, democratization is really required at, different levels and different forums. So it really needs to, happen everywhere, otherwise this is going to stay the same. Madhuresh, do you want to respond to this? And then I'll request Patty to, for her comment.
Just a small comment. I think what David mentioned that, when we were looking at these MSIs, so in many cases, even if it's started by or led by academic institutions or the private sector, they still want WHO to be there, even as a member, or they will put them in some capacity, because this brings the political legitimacy. And I think that's the biggest question, that they need these bodies to bring political legitimacy, which then gives them access to different kinds of things. And so that's one way of buying political legitimacy. The other way is that when WHO sets up some working group or any body it creates, any kind of body it creates, they come on there as members, or if they can't find a direct representative, then as David said, through the lobbying, you find a sympathetic professor, or you find an academic institution, or a research or a think tank, and they come in the roundabout way in those bodies to be a member and influence the agenda. So there is a web which is out there and which is constantly working much more than we are doing at any given rate. So it's really dangerous that how that web is operating. And I think more and more work of what the kind of work we did, either mapping or what David is doing, that needs to be done to constantly delegitimize them. So that's all I would say. Thank you.
Absolutely. Yeah, thanks, Madhuresh. I would now request Patty to make a comment, and after that, Genevieve.
Yeah, thanks very much. It's such a fantastic session. Thank you so much. And I mean, this has been I member of IBFAN, and we've worked, as you know, for 40 years. And part of that time, and particularly since 2010, 2000, when Gates came on the scene with GAIN and Global Alliance for Improved Nutrition, the whole thing took off in terms of multi-stakeholder action. So it's been a major, major problem because for IBFAN, because they centered in on infant and young child feeding. So thank you, David, for highlighting the corporate lobbying that went on, in the milk industry, because it was really, really difficult for us. And all these things took off the multi-stakeholders. And in fact, I joined, for my sins, the EU multi-stakeholder, what's it called, Platform for Action, Diet and Physical Activity. And it was very problematic. Some in IBFAN said, no, we shouldn't do it. I joined it because it existed, and I felt that we would highlight the problems with multi-stakeholder by being on it. But it was a huge risk because it does legitimize the thing, but we stopped our presence, because we had pre-meetings, we actually made sure that every time all the NGOs were together, the civil society were absolutely consistently saying what rubbish this was and how it wasn't getting anywhere. And in the end, we pulled out, as did the alcohol. So there are things you could do, but still the model went forward and as something that was quite useful. And the commission staff, I kept saying, why are you saying it's working? Because it's not working at all. There is no things. And I would use this in speeches at the assembly, and they'd get a bit cross and say, why do you have to say that? And I say, because it's true. It isn't actually getting you anywhere. It's slowing everything down, and it's making sure that just the industry is heard. And now, the reason I put in my comment here in the chat is that then you get this lobbying to try and take things off the agenda of WHO. And in 2020, that's what we saw. And David, you were sort of tracking how much money was going in, but they were trying to take the reporting back from member states on the code and marketing restrictions off the agenda. We called it the sunsetting of that facility that member states have a right to do. And I was intrigued by that. So I'd really like to look in more detail at the report you've got to see where that money, who's doing it, because at the time it was just as COVID was taking off and I was suffering from COVID at the EB, but I just thought, what's going on here? What's happening? And then since then, exposing, doing press conferences and press releases, the WHO said, okay, yes, we can see, but it's still there. They want it off the agenda. And that is making me nervous as well about how we write proposals and suggestions. It happens. The language is there. WHO uses it all the time, doesn't it? Partnership, trust, all these things. And you just, you do your critiques and you're thinking, am I supporting and legitimizing this very bad understanding that WHO has? I mean, Judith Richter has written a lot about WHO's conflict of interest policy, which is wrong, which is inaccurate. It doesn't make sense. Conflicts of interest are not about a distinction between you and somebody else. It's internal in the case of WHO. It's absolutely there, and they're not sorting it out. So anyway, I'll shut up. But thank you so much.
Thanks.
Thank you. It's really helpful for me to try and sort in my mind and have proof.
And I think the good news is that we have documentation of all this, which has been presented, something that we can really use in our struggle forward.
Fabulous.
David, do you want to give a quick any comment, or we'll go on to the other commenters, but also to just tell everybody that it's going to be 2:30 here. I mean, but we would want to maybe extend it for another 5-10 minutes because we already have 2 more hands there. Yeah, David.
I've actually got a question, because I was been wondering how delegations from governments in the global south, how they would feel about the US government kind of being lobbied to undermine WHO on behalf of transnational corporates that are based in the US. What would their reaction be to seeing this data kind of laid out so explicitly?
So I don't know who would be the best persons, even within our participants, to sort of respond to this. Maybe our colleagues who are participating in the WHO Watch, maybe Anna or anybody else. I don't know whether she's there, but let's keep this thing in mind, and we'll try and see if anybody is able to sort of respond to this. But I think it's a very important thing to investigate and interrogate. So hopefully we'll be doing that. So I will now request Genevieve to please make your comment, and after that, Axel.
Well, thank you. I think it's a bit of mind reading because I didn't raise my hand, so I'm a bit surprised to be in the panel, but I'm happy to ask a question. I've been listening very carefully. I'm rather from the agricultural sector and involved in food production, and multistakeholderism is a problem now in the international spaces like FAO and so on. And now I'm wondering how to be able to be taken into account as civil society. And this is also one question, how to also tackle the question. It seems that in the West, southern countries, people have been missing vaccine and treatments and so on. And in and northern countries, it was the other way around. We've been forced to take vaccines, and we were not able to choose our medicines. So the question is how to bring democracy in both places, because it is also the same lack of possibility to intervene. So how? Thank you.
Yeah, thanks, Genevieve. I think maybe we could take Axel's comment and then, then put it to the panelists in the interest of time. Yeah.
Thank you all. Thank you for giving me the floor. I'm sorry, I cannot turn my camera on. I have a remark and a question to FIFA. I think that I concur with what you said regarding global North agencies leading global pandemics management. But at the same time, how do we do? Because we know that leadership is only the reflection of what was accepted during the negotiations rounds. We have now IHR and pandemic treaty on the table. How do we do? What do we do for the paradigm to be changed really? Because what we are experiencing today is what was on the table in 2004, 2005. The IHR was 2005 was to protect global north from what can happen from the pestilence of global south. It has always been that. And I do remember that during my field work in Kenya in 2014, Kenyans were telling me, no, this is not fraud. This doesn't speak to us. Our issues are our health system. So we have countries' representatives accepting unequal, unfair norms on behalf of their government because of the knowledge power or of the strategic power. How do we change it? Because at the end of the day, what we are seeing as a political is the political reflection of the paradigm and power. How do we change that? I think that is my question. Thank you.
Thank you so much, I think, for bringing in this the issue of power. I think that's really what is at core of all these things that we are seeing. So I will now request Dr. Fifa Rahman and David McCoy to maybe respond to some of the questions that have come in, and also provide maybe a concluding some of your observations. And then after that, I'll request Harris to maybe respond to some of who's been involved in a lot of these multilateral discussions and has been a sort of observer in all of these. So to really respond to what even David was saying about how would countries feel if another country is being lobbied in this way. So Fifa, please go ahead.
Thanks very much. And I just got a notification that my internet connection is unstable, but if you can't hear me, just let me know. So the first one, civil society structures. So the Act Accelerator, we really had to push for it because Gavi wanted to nominate civil society representatives, and we were like, no, we select ourselves. And then it was this whole tug of war. And in the end, the vaccines pillar reps were selected, but to varying degrees of quality, right? I think the quality across the pillars differs. Some are cheerleaders, and some are going to be critical and attend all the meetings. So it's also about ensuring this compensation. And this is something that I made the point of, and I attended a sexual exploitation meeting in the WHO. It's in Geneva 3 weeks ago, and they were asking the same thing: how to establish civil society mechanisms and integrated compensation for CSOs is incredibly important. And the CSO model within the Act Accelerator is something to be built on, because we have civil society in each pillar. We have a lead civil society rep, myself in the Facilitation Council and principal group meetings. So, it needs to be built on for sure, and taken from there. And another thing that I meant to mention on that is that actually we're pretty imbalanced. A lot of us are global north. I've got a global south passport, but I am based in the global north, and a lot of us are based in the global north. And even though we recruit global south, somehow we need to figure out why the drop-offs occur, right? On the paradigm of power, Excel, I love that question. I don't know how to answer it, and we're trying, and we really need to hear from you as well in terms of the proposals that we're making as we go into these G20 discussions and these WHO discussions on pandemic preparedness and emergency response. how do we change that paradigm of power? I don't think we can address it without addressing white supremacy. And it's important to mention, everybody gasps when we talk about it, but white supremacy isn't just about the KKK. It's about you know, these white supremacist structures that undermine the opinions, the indigenous knowledge of the Global South and Global South experts, and what they want. And I wrote it in the chat that what happened at the Biden summit, LMIC governments were going health systems, health systems, health systems, health systems. Global North were going commodities, 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 commodities. It is supremacy, right? And it needs to be sorted. How? I don't know, Excel, and you and I can have a bilateral on that to see how we can do that. Thanks.
Yeah, thanks, Fifa. David?
I'll be brief just to say that, I mean, we're all here because we're wanting to protect WHO from being undermined, from being attacked. We see the importance of WHO. We see the importance of multilateral systems of governance. And I think one of the ways that we can do that is to understand also the lines of attack, the mechanisms, the narratives, the arguments that are being used to undermine. And here, I think one of the things we showed, it's the nature of that narrative. It's questioning the legitimacy of multilateralism itself, questioning the scientific credibility of WHO, and in so doing, also attacking science as a basis for, for understanding risk, for understanding the nature of hazards that are associated with commodities produced by the market. So I think it's important that we're able to kind of counter these lines of attack with counter narratives, and so that's just one contribution to the efforts that we're all making to protect the system of multilateral governance and WHO specifically. Thanks.
Yeah, thanks, David. Harris, yeah, please make your comment. Thanks.
Thank you. This has been a wonderful panel. I'd like to go back to the opening piece about power and health governance and the role that WHO is in the middle of being pressured at multiple levels to remove it from effective health governance. As on one side are the pressures on country delegates and country expertise, as David has outlined. Those government officials are under pressure on money, on lobbying by corporate interests in their capitals, in threats about you won't get or you'll get lower priorities for access to antiviral drugs or vaccines or things of that necessary nature. And there are enormous corporate and northern governmental pressures on the states and within the major industrialized countries from the corporate side, pressuring to limit and marginalize the WHO. On the other side is WHO is being marginalized by ACT. And by Act A, I'm sorry, Pfeiffer, I disagree with you. This is not a viable route forward. This multi-stakeholder group is taking out of the public domain issues which ought to be front and center in the public domain for civil society's accountable presence. So in this sense, WHO is being pressured on the power of global governance from country sides by the corporate lobbying and the pressures on Southern governments, and from the multi-stakeholder side saying WHO isn't the place to be. And I have been reviewing the Act A papers, and how they describe the WHO is increasingly in support services that the WHO could provide to ACT. And so this misdirected structure outside the arrangement undermines a prospect of growing multilateral, public, accountable global governance within the WHO community. And I think that this kind of work on multi-stakeholders, external threats to multilateralism is very, very important to continue working on. And I can look forward to sharing with some some of my newer research in the coming months. Thank you very much.
Thanks, Harris. And, I mean, we see, I just want to go back, to the mapping that was done. And we really see this work as a continuing dialogue, and we see that the mapping is alive, and we actually welcome the participants here to really add to that, database, and to also say that there is a whole database that is embedded within, that web page. Maybe we can share it again, where we have produced the report, and we really welcome you to contribute to that. And I think, and before I request Thomas to give the concluding remarks, and Juliana to give the vote of thanks. I think all of us here are here, because we believe that it is important to, build stronger, more democratic, multilateral systems, and, that are accountable to people's interest, and, really not to, profiteering or corporates. And let's hope we can, together sort of join in this struggle and go forward from there. And now I will request Thomas to give the concluding remarks, and then Juliana, you can take it from there to give the vote of thanks. You're unmuted. Okay. You're muted.
Yes, maybe Juliana first.
All right. Well, I would like to first thank G2H2 in the name of TNI for the incredible opportunity to speak about this alarming and growing issue to democracy and global governance, and also to the global South health, that is multistakeholderism. I'd like to remind you that the struggle is being carried out in many other sectors as well, and so it's important to acknowledge the role and importance of people's working group on multistakeholderism in this fight. Like Patti mentioned in her comment, this is a struggle we need to fight together. Finally, I would like to thank you, the panelists, Madhuresh Kumar, Fifa Rahman, David McCoy, and Paremoer for having this incredible discussion. And of course, Sulakshana and PHM for moderating and arranging this to happen. And just to say that this is not a simple struggle. It is determinant to the health of peoples and to the health of the planet. So we invite you all to resonate the message and engage with us in the fight. Thank you very much.
Yes, and thanks to you, Julian, and thanks to the team. I liked this session very much. And I think I liked also the spice that came into the conversation. I like that we started to paint things also in shades of gray, in between the black of multi-stakeholderism being bad and the good of WHO being the perfect multilateral institution. And what is really needed is the research, is the information, it's the evidence, it's looking into the details and into the small print. And so I was so happy to have this research undertaken by the team around TNI, and I'm so happy to have this new report by the team of David and colleagues. This is really what we need, I think, David, don't worry. If delegates from the Global South read your paper, they will react. They need to react, So they don't need to be here in the room. I think they will see it, hopefully. So we are at the end of a long week of policy debates. We close it here by saying just goodbye and thanks to everybody. Come back again next week, or let's say starting on Sunday, to meet each other and talk about what's going on there at the World Health Assembly in our daily WHA Today briefings, taking place every day starting at 1:30 Central European Summertime. You find the announcements on the websites of G2H2 and Medicus Mundi. And if you are in Geneva for the World Health Assembly, join the team of PHM and colleagues also for the launch of the alternative World Health Report, which is Global Health Watch. And the 6th edition has the title In the Shadow of the Pandemic. That's it for today, with repeated thanks and goodbye to everybody, closing here with.
Thanks. Javi, interpreter, had something to say. He has his hand up. I was just wondering.
I first say thanks to the interpreters also. So
yes,
Javi,
yes.
there is something.
Thanks very much to the interpreters. And The recording will be shared actually both in Spanish and English. We hope to put both videos up so that people who could not join us would be able to take advantage of this discussion. Yeah, thanks everyone.
Okay, it was accidental, so there was no hand by Javi. And closing here with and saying goodbye to you also. David, thanks a lot that you jumped into the conversation at the very last moment. That was really helpful, and I hope that we can make a bit of noise around your publication. Contribute to it, we will support.
Great, thank you. Thanks, and thanks for all your work as well. It's fantastic to see the hub having developed so well over the last few years.
Okay, and technically closing the session right now. Goodbye.